All right, welcome to today's program, To Specialize or Not, sponsored by ASDA's Career Compass, American Academy of Periodontology, and American Association of Oral Maxillofacial Surgeons. I'm Brooke Kachuras, ASDA's membership coordinator here at the central office in Chicago. Before we begin, note that all attendees are muted so that we don't pick up any background noise during the program. During the presentation, you will be able to ask questions of the presenters. You will notice a control panel on the right side of your screen. You can type into the question box at any time. At the end, we will answer as many questions as we can. We will also provide contact information for the presenters if you would like to email them directly. Career Compass is a resource to help prepare you for graduation and transition into the first steps in your career path. ASDA is excited to work with experts in the field, such as AMIS and AAP, to develop new programs and resources for you. Visit Career Compass to explore all it has to offer. I'd like to introduce our first speaker today. We have Dr. Ellie Bruno. She is an oral and maxillofacial surgeon practicing in the Chicagoland area. She is an alumna of Marquette University and the University of Buffalo. Following a 2-year general practice residency, Dr. Bruno completed her surgical residency at Indiana University. She has held several national positions and recently received a Professional Achievement Award in recognition of her outstanding leadership and contributions. She serves as a liaison for the Executive Committee of the Resident Association of American Association of Oral and Maxillofacial Surgeons. Please welcome Dr. Bruno.
Hi, good evening. My name is Dr. Ellie Bruno, and today I'm going to be presenting to you on maxillofacial surgery and the scope of our practice. So I just wanted to say thank you to ASDA and for you all for the opportunity to speak and talk to you a little bit about what it is that I've gone through in my training and what I do now in private practice. So that is me. I have had the good fortune of going to undergrad at Marquette University in Milwaukee. That kind of got my interest into dentistry at that point. Marquette has a dental school. After kind of researching a lot of different places and programs, I ultimately settled on the University at Buffalo, where I did my 4-year dental school training. After I completed dental school, I was a little uncertain of the exact pathway that I wanted to pursue. That led me to a 2-year general practice residency down in Charlotte, North Carolina. From there, that's where I really developed my passion for maxillofacial surgery. I applied to several programs across the country after doing multiple externships and then ultimately landed in Indiana. From Indiana, I had the great opportunity of getting involved with AMIS, which is our premier association for oral maxillofacial surgeons, and that led to eventual private practice here in the Chicagoland area. So when we are talking about maxillofacial surgery training in the United States, there's 101 training programs. 54% of all current training programs are the 4-year programs or a certificate level program. As you can see here, 46% are a 6-year combined dual degree program. That would be an MD along with the maxillofacial surgery certificate. The scope of practice and employment opportunities, both in academics and private practice, are identical regardless of the educational path chosen. Right now, currently, there's always around 1,160 or so residents that are currently within a residency training program. And the majority, as you can see, are reflected in the single degree programs. Approximately 250 or so residents will graduate each year from a COTA accredited oral maxillofacial surgery program. Generally speaking, when we look at the population of practicing maxillofacial surgeons, 25% would be considered the dual degreed, both MD, DDS, or MD, DMD degreed surgeons. And it should be noted that dual degree surgeons work also both in private practice and academics. Their job selection is identical to certificate holders. When we are then talking about training, once you get accepted into a maxillofacial surgery program, there is two sort of pathways that you will pursue, and it's dependent on CODA accreditation. Ironically, the 6-year program is actually very similar to a 4-year program in that 4 years are spent doing medical and surgical rotations, and the 2 additional years are traditionally spent within the medical school setting. During the medical training, it varies from institution slightly, but you will typically have rotations in internal medicine or kind of general hospitalist medicine, and then it goes into other critical care, ICU rotations. Sometimes you'll have points in time where you'll train in cardiology, pulmonology, and infectious disease, as those are very common to maxillofacial surgery patients. From a surgical standpoint, you'll have multiple months spent on a variety of surgical services. You spend over 30 months simply on your own maxillofacial surgery service, performing all of the traditional types of surgeries. In addition to that, you have to spend a certain amount of time on other surgical services. The vast majority of most programs would consider that general surgery or even trauma surgery. There are usually several months additionally spent on very similar types of surgical training programs, such as otolaryngology or ENT surgery and plastic surgery. All maxillofacial surgery residents complete an anesthesia rotation that is several months long. During this time, you are trained in both pediatric and adult anesthesia that covers intravenous sedation and full-blown general anesthesia. Many times you are working right alongside an anesthesia resident or an anesthesiologist attending, and you are treating patients that need hip replacements and trauma surgery like you are the anesthesiologist. So that's a very unique portion of our training that I actually came to enjoy during my 4 years at Indiana University. So what's so great about being an oral surgeon? Well, you have to get through the residency portion first, but residency is very unique in our specialty in that I think the lifestyle is very similar to medical residency. We are extraordinarily fortunate that all maxillofacial surgery programs are actually funded through GME or graduate medical education. So what that means is we have a paycheck from the GME office, which is not usually affiliated that intricately with a dental school. So we are fortunate enough to have all the same benefits such as healthcare and 401k and disability insurance that are afforded to all the other medical residents at the institution. The typical day in the life of a surgery resident, it's probably going to be a little on the early side. It's before the dental school waking hours sometimes. We typically would start the day with rounding on our current surgical patients, checking on everyone, making sure things are going smoothly, getting patients ready and prepared for surgeries that day. Then traditionally you would transition into either lectures or you may go straight to your clinic versus surgeries. And we are pretty much the experts in a whole variety of surgeries. We are fortunate enough that every day can be really different. Our patients, they can be presenting in our clinic for dental alveolar surgery. Most people know that we primarily take out third molars and impacted teeth. We do lots of biopsies, any kind of pre-prosthetic surgery, implant surgeries. Typically in the operating room, you're going to see some of our larger caseloads, temporomandibular joint procedures such as total joint replacements, cleft lip and palate procedures, trauma surgery, whether that's a mandible fracture, a cheekbone fracture, which is a zygomaticomaxillary complex fracture, orbital fractures, anything you name it on the face, we will treat that patient. We also do a lot of pathology, both benign and malignant. Head and neck cancer is definitely in our wheelhouse. reconstructive surgery, such as radial forearm free flaps and fibulas. We can really do it all when it comes to head and neck cancers. And really, those are really great opportunities to work alongside some of our plastic surgeon colleagues and our otolaryngology teams on head and neck cancer teams. So they can be long hours, but you meet a variety of really great people. From the day progressing through the surgeries, whether they're more clinic-based surgeries or if they're general anesthetic cases performed in the operating room. Some programs have lectures at night, journal clubs, different activities like that. And obviously there's the component of being on call. So what that looks like at every institution is very different. I would say many institutions share facial trauma call if there are plastic surgery and otolaryngology residents as well. And many times, to the average emergency room patient, they will not really know if you are a plastic surgery resident, ENT, or OMFS. From there, it's just kind of another day. So long hours, but definitely it's a really interesting training experience. So once you survive the residency lifestyle, then you get to become part of this great big world of being a real doctor. So I am fortunate enough that I am in private practice. So what my schedule looks like, I typically work 8 to 5 Monday through Thursday, and I'm there a couple hours on a Friday. I take trauma call at a level 2 hospital every 6 weeks. And the other doctors during the 5 weeks are both some of my partners and people that are plastic surgeons and ENT doctors. So we still have that camaraderie among surgical specialties. So I think it's a pretty nice schedule. It's reflective of a lot of my general dentist referrals. And what's great about private practice, as I know it, is that there's quite a large scope of still surgical cases in private practice. We are still seeing 10 a.m. can be a temporal mandibular joint patient, transitioning into a dental alveolar patient, transitioning into more of a pathology patient. We still treat facial trauma in my scope of practice, and it just makes it for a very interesting day. Nothing is ever the same, and it doesn't really get routine. And it's a great way to also develop strong relationships with the general dentists in the community that may rely on you for, the surgical services you can provide, but also just basic knowledge, since they are generally familiar with our level of education. So if something really kind of rare or unusual comes across, I'm just a phone call away for any of those individuals. We are very fortunate enough that some of our larger cases and even some of our smaller dental alveolar procedures really do tend to impact patients' lives. You probably all can get the same effect with some of these beautiful aesthetic restorations that you're trained to do. Some of our really significant life-changing surgeries, they can range from, a patient getting a new joint that they now can open their mouth appropriately, to patients surviving their cancer surgeries. So it just creates a really interesting day-to-day interaction with your community. As most of the specialties within dentistry, I think most people understand the complexities of our training and the additional 4 to 6 years that it does take to become part of the maxillofacial surgery community. We hope to always be looked at as just a knowledge base and a resource, and we're always just kind of there for whoever may need us. Obviously, part of that training, what that comes along with is compensation. So that's always an added benefit to becoming part of the OMFS club. So how do you actually become a maxillofacial surgeon? You're going to want to have certain level of grades and class rank. And I know not every place now does class rank, but there's different ways that you can optimize your application: volunteering experiences, research experiences, and lots of externships. Externships really kind of will give you the plunge into a day in the life of a resident, and it'll expose you to surgical attendings, and it can kind of get your foot in the door depending on the program. So anyone that is remotely interested in oral maxillofacial surgery, you should definitely do as many externships as possible. And you can kind of see the nuances between maybe a dental school-based program versus a hospital-based trauma surgery program, someone that is a 4-year versus a 6-year, and large programs where they have over 16 residents versus smaller programs where there may only be 4 residents. Obviously, as a component of getting into maxillofacial surgery, you will need to take the CBSE. It's a standardized exam taken at a testing center that is a secure testing center, and it's very similar to the first part of step 1 of the medical route. So that's where kind of the theory and the thought behind this specific exam being tailored for maxillofacial surgery applicants comes in. So just to kind of wrap things up, we are just incredibly fortunate for the opportunity to be kind of the in-between dentistry and medicine. And I think we have a very unique role and a niche to that degree. We are extraordinarily grateful to all of the general dentists and our other specialists. I just today called an endodontist and called a periodontist. So we work very closely with our other specialties, and our position is unique in that we still also get the surgical specialties involved, like ENT and plastic surgery. We're always grateful for our general dentists. Without them, we would have no referral base. And in the academic world, that is just usually their referrals sometimes come from either general dentists or other oral maxillofacial surgeons to get the patients kind of tuned into the academic realm. So once again, if you are interested in this wonderful, amazing specialty, call and visit programs, do as many externships. Amos has many resources to that end as to how to get involved in externships and how to set those things up and kind of guide you throughout that process. And please just know that we are definitely friends of dentists, and we just hope to work with ASDA, the ADA, and our own surgical association to protect and advance dentistry in the future. So thank you.
Thank you very much, Dr. Bruno. Next, I would like to introduce Dr. Ramzi Abu-Araj. He is a 2003 graduate of the St. Joseph University School of Dentistry in Lebanon. He received his periodontology certificate and MS degree from the University of Alabama at Birmingham. He is an associate professor and clinic director of the postgraduate clinic at UAB. He is a diplomat of the American Board of Periodontology and currently serves as chair of the American Academy of Periodontology Education Committee. Please welcome Dr. Abu-Araj.
Good evening, everyone. First, I'd like to thank ASDA for inviting me to be part of this specialty training type of questions that you might have, as well as like to thank you all for being with us on this webinar at the end of your busy days. I'd like to first start by trying to answer the question of to specialize or not. And I can tell you about how my experience went through coming to a decision about this topic. I try to summarize now for you as the way of basically how I went through this process of making that decision. And one of the main factors was that realizing that dental school did not suffice for getting the exposure to all aspects of dentistry. If you think about 4 years of dental school, there simply isn't enough time in 4 years to put everything together in terms of knowledge and skill to be able to perform all kinds of dentistry to a proficient level or to a level that satisfies you. At least it didn't for me. think about all the advances that we have had in dentistry over the past years, and yet we still have the same number of years for dental school as we did 60 or 70 years ago. Uh, One personal item for me is that I always have to think about these questions. Do I feel comfortable providing this procedure or this service to one of my family members? And if the answer is yes, then I would go ahead and do it. And I felt that specialty training would help me achieve that a little bit better. As a specialist, you go through up to 4 years, and in some cases 6 years of focused training that may be equivalent in some cases to 10 or 15 years of the same in general practice. And what I mean by that is not productivity, but mostly it's exposure to specific procedures or aspects of dentistry that you do in a very intense way over a residency program that allow you to become a lot more proficient at that. In residency, you also get to learn in an environment that basically works in an exponential way, that learning that happens for you, because you do feed off of your co-residents, the faculty members, and everybody learns in that environment a little bit better. And also, don't forget that residency will teach you to interact in a collaborative way, not only in residency, but most importantly for the rest of your life. There is nothing that, if you're a specialist at something, you cannot do things on your own. You have to collaborate with other specialists. It's just a given. And you start learning that in residency, and it instills in you the spirit of collaboration with others over the rest of your career. Now, let's say that you decide to specialize. You also, of course, have to think about some of the logistics, such as time commitment or finances. And in some cases, your family situation may not allow you to make that decision to say, I'm going to specialize, or I'm going to pursue a 2 or 3 or 4 year program in residency training. And very important to look up all the requirements that are needed for your specialty that interests you. And in some cases, some programs have within the same specialty have specific requirements that work for them. So like Dr. Bruno outlined for oral surgery, there is the NBME CBSE exam that you would have to undergo if you are pursuing that. Always you have to work backwards. When you make up your mind about submitting an application, you have to set a deadline for yourself to gather all the required information. And that would be your own CV, your own personal statement, but also the letters of recommendation that you have to seek from people that know you best and can speak well of you. Of course, at your institution, and some cases outside of your institution. And do not wait till the last minute to upload those documents. And at time of interview or interview day, you always have to come prepared. If you're interested in a certain program, make sure you read up on that program. Make sure you read up on those folks that are going to be interviewing you, so that you have something to talk to them about, to show your interest. But more than anything, you have to be yourself. You are going to be in that program for 2 up to 4 years, depending on what specialty you're seeking. And you want them to know you as far as who you are to the best of your ability, so that they can make an informed decision, and you can also see if you are a good fit for that program. So of course you can select a number of specialties, and I listed here only the ones that are recognized by the ADA, and there are some others. For the next section of my presentation, I will talk to you why you should select periodontology. And I'm not going to define periodontology to you because I believe you all know what that is. But I will mostly speak to you about why I chose periodontology, why I think you should consider periodontology for your specialty training. I'm using this patient example here because if we look at this patient and at those findings, you know, a lot of times when you see findings like these, and you look at these radiographs and you appreciate the amount of destruction that has happened, the amount of bone loss that has happened, it's quick to jump to the idea of this is a terminal dentition. We have to think about sacrificing these teeth and going ahead and thinking of treatment options to replace them. But things change if I told you that this patient, for example, has been in periodontal maintenance for about 13 years. And this is how he presents before we clean his teeth at maintenance visits. So this is a patient that a periodontist at some point was able to, using proper diagnostics, proper risk assessment, proper treatments, and understanding of the complex interplay between the etiology and the host, to change their life in that way. And they still maintain their teeth. They can always have the implants. At some point, they might need them. But for as long as possible, that could have been avoided. This is another patient where, again, that would have been a terminal situation for many clinicians when they look at that. But again, understanding of the biological principles that govern this whole relationship of host and etiology can help you figure out the solutions for this patient that may be saving their teeth, and with active periodontal therapy ending with some orthodontics that eventually would help them maintain their dentition and improve their oral health. Periodontology allows you to dive into the regeneration type of medicine, if you will. We are able to reconstruct missing periodontal tissues. And this is not something that is that easy if you think about the unique environment in which the periodontium sits. And this can be done predictably through a deep understanding of the biology of the wound healing mechanisms, so that we can manipulate those wound healing mechanisms to our advantage using certain growth factors, certain biomaterials, certain biologics, and surgical techniques, of course, to be able to achieve outcomes like this. We are also able to treat peri-implant diseases, but again, we have to understand the biology behind all that, where we can use the same principles applied on implants to be able to restore missing tissues in the oral cavity. Sometimes we have to replace missing soft tissues. And how many cases have we seen where a patient like this one, where you can see their roots, they're being replaced with longer crowns, whereas the missing tissue here is the soft tissue, and that can be predictably replaced as well. In other cases, periodontology, a residency in periodontology would allow you to gain that knowledge, again, about the same wound healing principles that help guide your treatment options to be able to help this patient replace their missing teeth with dental implants. In other cases, we have to do the opposite. What you learn in periodontology is that there are some resective procedures that may need to happen in some cases, or in a lot of cases, to treat and control periodontal disease, but others for aesthetics, such as this patient who eventually had to undergo some aesthetic crown lengthening after proper diagnostics, after proper treatment planning, and that happens all the time in collaboration with a restoring dentist or a prosthodontist, and in some cases an orthodontist, so we can achieve those outcomes where we can take them from an asymmetry situation and the loss of harmony of the gingival structures to something that is far more aesthetic, and then comes the rest of the work through that collaboration where the restoring dentist or the prosthodontist can improve that patient's smile for going from there. When teeth are lost, the option obviously is to replace them with there are several viable options, but one of them is dental implants, and that happens in context of achieving periodontal health first. Otherwise, that implant will suffer the same thing that allowed the teeth to be lost. And it could be a straightforward, more or less case like this, with minimal soft tissue or hard tissue reconstruction. In other cases, things can be more complex, requiring some more treatment planning and collaboration, to where a tooth that has suffered a resorption can be, for example, slowly and progressively replaced with an architecture that resembles what the patient, or even is better than what the patient even had, and that follows the biological principles and the architecture of the existing dentition. Of course, other cases are more advanced, and residency training helps you understand these options, and that can be through an oral surgery residency as well, obviously, in more advanced cases where soft and hard tissue reconstructions is necessary, in collaboration with a prosthodontist to achieve outcomes like these. Again, this is another example to to talk about what dentistry can do today. And again, in many cases, when a patient like this shows up with findings like we see here on this radiograph, we are quick to jump at removing these teeth, considering that they're hopeless, and thinking about implant solutions with overdentures or hybrids or things like that. And that is that these are options, but one of the more viable options is let's try and save most of this patient's dentition, which we did, and we still were able to replace the missing structures with dental implants after hard and soft tissue reconstruction. So in summary, I'd like to summarize why periodontology. It does combine oral health, function, and aesthetics, and it highlights the optimizing of the oral and overall health care of the patient through proper risk assessment and diagnostics. It is patient-centered because it uses biology as foundation for decision making. Team collaboration, I cannot emphasize this or overemphasize this, because everything the periodontist does, it happens in collaboration with other specialists in order to improve that patient's outcome and their oral health. It allows you to build long-term relationships and interactions, not only with your peers and dentists and other specialists, but also, and most importantly, with your patients that you will see for a long time in your practices. Comprehensive approach, recognizing that periodontal health is a cornerstone in dentistry that allows you to make sure that this patient has the right foundation to support the other needs that they have. Again, periodontium is a unique environment in the body, if you think about it, and regenerating missing periodontal tissues is somewhat unique in that perspective. Periodontology also uses evidence-based research and practice, and we are at the cutting edge of that. We are always in pursuit of new growth factors, of new techniques, of new biomaterials, of new understanding of the diagnostics and the mechanistic effects of the pathogenesis of this destructive disease in order to improve our patient health. And because of that, it's considered a dynamic specialty. Of course, it combines some of the surgical aspects, as I tried to highlight to you in the previous slides. It puts the periodontal health as a center to dental implant success, which is not a surprise to all of you. And of course, it allows you to replace the missing teeth with dental implants after proper risk assessment, site development, and implant surgery. We also have an outstanding academy that values science, research, education, and patient care at the same time. And therefore, we're all proud to be periodontists, and this is one big reason why. And if I were to briefly say why periodontology, my answer is very simple: because it's awesome. And I thank you for your attention. And I'd like to show you here one of our some of our awesome individuals at the University of Alabama at Birmingham, our family of residents, faculty, and friends. And thanks a lot for your attention. And hopefully you have some questions for us that I hope we can answer.
Thank you very much. All right, it is now time for the questions portion of our webinar. We're going to do our best to answer all of the questions, but if we don't get to yours, you can email it directly to the presenter. All right, so this first question, I believe, is for Dr. Bruno. It says, what distinguishes the 4-year certificate from the 6-year MD, DDM, or DDS aside from the MD title? More specifically, are the job opportunities and the day-to-day lives of these OMFS specialists exactly the same?
The simple answer is yes, we are identical. We are recognized in our hospital environment as identical to anyone that has a 6-year degree versus a 4-year degree. So if you're in private practice where you still have hospital-based affiliations, there's no difference. If you decide to go into academic practice and you want to be part of either residency training or a dental school, institutional setting, there's no difference as well. In many, many surgery programs, there are both faculty positions and faculty staff that have both the 6-year degree and the 4-year degree working right alongside. Your opportunities for fellowships in cosmetic surgery, head and neck cancer, will not be affected whether you have a 4-year or 6-year degree.
All right, the next question is for Dr. Abu Araj. It is there any push for periodontal residencies to receive government funding for stipends during residency? The cost is very deterring, especially when already in serious debt from dental school.
To my knowledge, that is not something that is in play at the moment. I'm not sure. I don't have any information about whether that's something that would be sought in the future. Right now, it's mostly for OMS, like Dr. Bruna had mentioned, and some of the GPR programs that benefit from that.
All right, this next one is for you again. What does life after residency look for a periodontist? Do you most go into private practice, or do you stay in an academic setting?
Like most other residencies, the majority would go into private practice. But I will say that many of those folks like to come and give back to their institutions or the places where they end up practicing through part-time teaching. But full-time academics, just like other specialties, I would think, I don't have hard numbers there, but I would think that it would be the majority going to private practice.
Dr. Bruno, any idea how your military colleagues matched up to civilian residency program colleagues? I'm an HPSP student interested in OMFS, wanting to know how they compare.
I happen to know someone that actually did complete a military training program. The military training programs are outstanding. I think they are very competitive and they offer pretty much the same educational opportunities. I don't think that there's a drastic difference whether it's a military-based program or a traditional non-military-based program. There are some certain opportunities for military personnel to enter into traditional regular institutional positioning, and it's different per type of military branch, but the specific to the military programs are all very strong in the United States.
This question is for you again, Dr. Bruno. In regards to OMS, I often hear you need to have a good GPA, class rank, and CBSE score. Can you give some specific numbers to set as a goal? Does this differ between the 4 and 6-year programs?
My simple answer is be at the top, whatever the top means. I would say that generally speaking, something over at least a 70 on the CBSE is considered relatively competitive, and that number kind of is based off of how the medical students have performed. You have to keep in mind that it's a relatively new testing methodology, and we just don't have a whole host of data to demonstrate what a very specific number is. In terms of class rank and in terms of GPA, you obviously want to have something competitive, but the challenge is that you're being compared to other applicants that may have no class rank and no GPA. So the numbers kind of change over the last several years because of that some people may have one of these numbers, all 3, or some varying combination of that. But I would definitely say that we are interested in the best and brightest of the dental students to come into our specialty. So if you work hard, there are other things that can supplement an application that isn't simply a number. It's really good, strong working relationships with your institutional OMS people, and your performance on rotations and letters of recommendation are all equally as strong and valuable.
Dr. Abu Araj, what is the typical day like in the life of a periodontist, whether private practice or other areas?
It's as I tried to highlight in what I presented, it's a very varied type of specialty where you, if you're in private practice, you'll be having several things going on at the same time. You'll have a hygienist or more seeing your patients for periodontal maintenance. And at the same time, you are conducting new patient exams or doing follow-ups on your procedures or doing procedures. And while seeing your patients who are being seen for maintenance. Most periodontists do practice 4 days a week, and I know some practice 5 days a week, and some others, they have that fifth day of the week saved for bigger procedures when they have to be dedicated only for 1 or 2 patients, let's say. In academics, it's a little different, just like any faculty member that the attendees would probably know from their institutions. Your life is kind of balanced between different aspects, and that, of course, depends on what you are hired to do. A lot of people do a lot of clinical, others do a lot of research, and there are people who do that mix in between, where you spend your week teaching in the classroom or in the clinics with the residents and students, and you have time for faculty practice that portion of the week, and then of course you have time for clinical research and service to your institution. You have your advantages and disadvantages for being here or there. Of course, you benefit from the great relationship of working with peers all day long and all kinds of specialties when you are in academics. Not that you cannot do that in private practice, but they're not as readily available as they might be at your institution if you're in full-time academics. Of course, when you are in private practice, you want to take a vacation, you have to think about, it's a small business after all, and you have, I think Dr. Bruno can speak more to that, and that affects your staff, whatever you have to do to manage that business. And in academics, you still have to manage somebody to cover for your duties. You can't just take off. However, you do have a bit more flexibility there in coordinating when you have to be out for certain things. And of course, the pay or salary, I'm not trying to avoid the elephant in the room, but that obviously is a big one that distinguishes from a standpoint of what your salary might be in private practice as a periodontist, a private practitioner, or as an academician.
This next question, I think, is for both of you. So we'll start with Dr. Bruno. If you do not get accepted to your specialty on your first try, do you recommend doing a GPR or AEGD and then apply again? Or would it be better to work as a general dentist to try and pay off some debt?
So if you are interested in oral maxillofacial surgery, I would deter you from both of those options. There are non-categorical externships at a variety of oral surgery programs throughout the country. What that means is you are not part of the match. You are not one of the essential residents that advances from the first year of OMFS to the second year. You are simply contracted for 1 year. Your rotational schedule may look a little bit different, but that is definitely an immersive experience of what it is to be a maxillofacial surgery resident. You are still paid through the GME, and it's almost as if you are usually not that different than your other cohorts that are categorical residents within the program. It gives you the opportunity to have exposure into the operating room and to make relationships with that institutional staff, and that is extraordinarily important for boosting your resume and boosting your application. Working in private practice is actually probably not, it would almost be a negative. And the reason why is because it's very difficult to go from a private practice environment performing general dental procedures to then get back into the swing of residency. And it tends to be not well received when there are externship opportunities. It's perceived that if this is something you really, really want, there's very specific opportunities through these a full year internship at a program that would be seen as much more ideal. While I did a GPR and that's how I became interested in oral surgery, it didn't serve as a substitute because I didn't apply to oral surgery until after I completed the GPR. That can be a mixed bag. Sometimes there are great GPR programs where they work right alongside an oral surgery residency. But I would highly encourage someone who would not get in the first round of match year one to do an internship for 1 year in a surgical training program.
Dr. Abu-Araj, your thoughts?
Yeah, for periodontology, unfortunately, we don't have the non-categorical residencies like Dr. Bruno was saying about OMS, and that it's not an option. So I do think that them pursuing a general GPR residency type approach or private practice is not going to be a negative when they are applying again to a periodontal program. I have to kind of highlight that, as I did outline in my presentation, that a lot of what periodontist does is in collaboration with other specialties. So when someone sometimes goes to a GPR program and gains that knowledge in those other types of specialties that are essential for a periodontist to even understand more about, which would make you sometimes a better periodontist. So I wouldn't say that everybody who applies to perio has to go to a GPR before, but if you applied and you were not successful and your passion is periodontology, you should improve yourself in the other aspects of dentistry as an option, or work in private practice and reapply again, showing your interest. Talk to a periodontist in your community. Shadow somebody, maybe work on some research projects in periodontology with someone who does that to show your interest. Yeah, but we don't have those options. I would, though, echo what Dr. Bruno said in her talk earlier about externships. They're very important for people to get to know these applicants, whether the first or second time around. Because with the schools that have no grades or no rank, it's becoming harder and harder. And for the applicant to make themselves known to these programs that they're interested in, externships offer a great opportunity, which would be sometimes for a few days and others for a week or less. But this is one way of showing your interest and making sure that that's the right place for you, and them knowing whether you're the right fit for their program.
This is another question that I believe can be posed to both of you. How did deciding to specialize affect your family life in terms of starting a family, frequently relocating for education, or first job offers? Dr. Bruno?
So in terms of my family, I was fortunate enough that throughout my different aspects of training, I was actually a plane ride away. And despite my residency training, I could get back to my family. Most residency programs offer full unrestricted vacation, somewhere between 2 and 4 weeks per year. So that wasn't that much of a deterrent to me. I am obviously a female in maxillofacial surgery, and we're a little rare in my particular specialty. We're hovering around anywhere from 9 to 15%, whether you're looking at practicing surgeons versus what the residency population looks like. I am, full disclosure, not married and I don't have children, but that is not a reflection of the residency at all. I've had quite a great time traveling across the country, being involved in AMIS and different things that you can do whatever it is that you would like to do from a personal standpoint. I don't think that a myth that is perpetuated within this surgical field is that you have to kind of put your personal life aside for 4 to 6 years, focus on the surgery training, and then you can kind of resume normal life afterwards. And while our residency is very rigorous and it can have time constraints, there are plenty of residents that have gone through marriages and have children and bought houses and done everything that your typical late 20s, early 30s, or even older people do.
I agree with Dr. Bruno about not letting your family situation be in the way of pursuing your passion. However, you have to find the balance between the two. You have to do both well, and it's a very hard balance to have. But you could be successful at it because you have to be there for your family, and you have to be there full focus for your program so you can be successful. In my personal experience, my wife is a full-time orthodontist that also works where I do, and we had our first child when I was in residency. So that was not the easiest thing to go through, obviously, but also you can find a way to balance your life to where you still perform well in residency and gain the knowledge you're supposed to and perform at a high level, and at the same time be a parent and a spouse. And I think you don't have to interrupt one for the other.
Okay, so we have time for one more question. This is for both doctors. What types of things can a pre-doc dental student do to expose themselves more to a specialty outside of a clinical rotation? Dr. Bruno?
Outside of a clinical rotation, I would say if you wanted to become more familiar with with generally our scope, a lot of oral maxillofacial surgeons work in a hospital, so that's a different type of learning environment. We have our journal, so reading as much about oral surgery. We have hundreds of textbooks and journal articles. You can spend time with residents, spend time in the dental school clinics. So those are still dental students, obviously, performing oral surgery procedures, usually under the supervision of an oral surgeon or working closely with the oral surgery residents, if that's a possibility. We have many, many great meetings, both at our surgical association level and also through ASDA. They have, when I was a dental student, they had lots of amazing, unique opportunities for both dental students and pre-doctoral students to really kind of learn all that you can, and just, any kind of free time that you have, that would be sort of my recommendation. But obviously the best would be clinical experience, spend time with the doctors, spend time with the residents.
Dr. Abu-Raj?
My answer was going to be very similar to Dr. Bruno's. I would definitely recommend they talk to the residents. The residents are your best resource if you want to know more about a specialty. They can tell it as it is, if you will, and they can tell you the good, bad, and the ugly more than what we can say. And I think talking to them about what their daily life is going to be helpful to get you through a residency mode. And as far as learning more about the specialty and knowing if that's the right thing for you, again, a couple of things that we may have already said, but go to your periodontist in the community. If somebody, even you don't know, call them up and tell them you're interested. They love to have students around and to show you what they do in their private practice setting, because that may be likely what you will end up doing after residency. So you know the scope of what they do and if this is the right thing for you. And of course, like Dr. Bruno mentioned, you can go to meetings about that specialty or meetings such as AADR, IADR, where you get exposed to a lot of what happens behind the scenes and different specialties and their research and scholarly activities. And of course, the ASDA resources for that matter, and the ADA.
Thank you so much, everyone, for all of your wonderful questions. If you are looking for more career-focused education, join us live at National Leadership Conference in Chicago. Registration is now open, or be sure to register for any of our upcoming Career Compass webinars this week specifically. We'd like to thank our participating in tonight's program. We would also like to thank our speakers, Dr. Bruno with AMIS and Dr. Abu-Raj with AAP, for presenting tonight's program. This program was recorded and it will be posted on ASDA's website and emailed to all participants. Participants who complete the survey at the conclusion of the webinar will be entered into a drawing for a leather portfolio and a gift certificate to make your own business cards. Thank you so much for joining us, and enjoy the rest of Career Week.
Thank you.
Night.